Hi, and thank you for joining us today for the Iowa Public Health Association's third Thursday Lunch and Learn web series. So this is organized by IPHA's Education Committee, and my name is Chelsea Keenan. I'm going to be your host for this lunch hour. So I am a second-year MPH student at the University of Iowa, and thank you guys so much for joining us. We dedicate this time each month to talk about some successes and detours that different public health professionals are dealing with across Iowa. The point is really to connect and learn and strengthen the voice of public health in our state. So we're really glad that you're here today, and we hope that you'll be joining us again next month. So today we've got Black Hawk County Public Health with us, and they're going to talk a little bit about their systems thinking work that they're doing and how they're hoping that it's going to better serve their community. So before we get to that, just a couple of housekeeping items for those who are joining us. Your video should be off and your microphone should be on mute, but just make sure that that's the case so everyone can enjoy our presentation and listen to our speakers talking. And if you've got any questions that you want me to ask any one of our speakers, please feel free to send me a message using the chat function, and I will do my best to try to field those questions. So we're going to start off by having our panelists introduce themselves. So today we've got Dr. Nafissa Cisse Egbuonye, who's the Public Health Director for Black Hawk County, and we've got Dr. Chris Haymaker, who's a pediatric psychologist. So Nafissa, do you want to start off by just explaining a little bit about who you are and what you're doing over in Black Hawk County?
Okay. Well, thank you, Chelsea. Who I am, I'm originally from West Africa, Niger. But as you can hear from my accent, I've been here for quite a number of years. But I consider myself to be well-versed in the American landscape. So actually, my first journey, arrival to this country was in Illinois. So the Midwest is heart to me. And I've lived everywhere in the east, the south, and the western regions of this country. I've been here at Black Hawk County for about 3 years now. It's just been an exciting place to be, and with the diversity that's here and continues to occur, and the health department transforming. So it's been really exciting.
Great. And Chris, would you give us a little introduction?
Sure, I'd love to. I just want to say I feel very fortunate to have been able to work with Nafissa over the past few years in my role as the behavioral science faculty at a family medicine residency program here in Black Hawk County. And part of the focus of that and part of my interest really is in health equity and in helping to teach our family physicians empathy and compassion for folks who are not experiencing health equity. And so it was in that role that I really met and got to know Dr. Egbuonye so well. And I think just a little bit of personal background. It's possible that Dr. Egbuonye and I crossed paths in Illinois. That's where I went for my undergraduate degree. I grew up in Indiana, and then I was also in Ohio at Ohio State for my internship and postdoc as a pediatric psychologist. And then I've been in the community for about 15 years practicing as a pediatric psychologist and then as a behavioral science faculty for the last 5 years.
Great. Well, thank you guys both so much. We're looking forward to this conversation. So why don't we start off with just talking a little bit about the background of this work that you guys are doing and why equity work was something Black Hawk County Public Health wanted to focus on.
So I think equity work is important for everybody. I don't, so it's not, I think especially for local health departments, it's not just about Black Hawk County. If we truly are going to focus on population health, equity has to be a framework. And so for us, it's just a natural opportunity for us to focus on that. But beyond that, we have always seen the disparities here in Black Hawk County, especially as it relates to the different populations, marginalized groups. And back in November of last year, the 24/7 article that came out, Waterloo being the worst place for African Americans, for us, it was actually, it was sad, but it was an opportunity. It was what we needed to bring light to the issues that we already knew existed. And so I think it just positioned us better that this information came, and now more people were interested in understanding the causes of these inequities and what we can do to move the needle forward. So I think that's what really positioned us. But beyond that, when you look at population health, and we continue to see the disparities in the data over time, and we haven't been able to close that gap, we have to start asking ourselves, what are the causes of these inequities, and why is it that some of the public health programs have not been able to achieve the closure or reduce the gap in the disparities? And I think for us, it goes beyond just looking at disease prevention, but understanding the root causes of the inequities, and also taking on a multidisciplinary approach, which for me is really systems thinking.
Yeah, absolutely. And so from a public health perspective, how does this translate into practice? So like, what have you been doing with the systems thinking to kind of work at this?
So from a public health perspective, and I'm going to take a step back because I think there's an element that we're also not discussing. From a public health perspective, practitioners over time have been trained, whether it's a public health nurse or community health reach worker, to deliver, to ensure that the deliverables of the program are being met. But we're not talking about equity in the sense of why those inequities, and I think one of the factors is discussing race relations in this country. And for us in practice, it's actually introducing our employees to that, and for them to understand the historical causes of these inequities, so that they understand, oh, okay, this is actually structural racism, that there are structures set in place that continues to perpetuate this cycle. And so it's been quite an eye-opener. Part of doing that in practice is also to be able to create a safe and brave space for people to be vulnerable, to ask questions, and you give people the space and opportunity to also evaluate where they are, and because it's a bit of a rewiring that occurs. I know that one particular staff person during some of our workshops stated, why am I here at 30 years old learning about redlining, learning about how racism truly impacts our structural behaviors. And so it's rewiring. One of the things that we realize also, when you start doing equity work, you cannot disconnect the personal and the professional. So you cannot come to the health department and say, oh, I truly believe in equity work, but then go back home and not believe it. So we've had to really create structures in place and give people the opportunity to say, this is actually not settling well with me, or it's not the direction in which I thought I wanted my profession to be. And so you have to be okay with that. And so I think those are some of the things that we've it's been an eye-opener to us as leaders within the organization in terms of just introducing people to equity. It's a lot of education, so a lot of education currently is going on internally, and you see those that are now applying some of what they've learned theoretically into practice, and that's just been rewarding for us to see.
Yeah, definitely. So it sounds like there was a lot of kind of building blocks and setting a baseline to get everyone on the same page so you guys can kind of move forward with your next steps.
Mm-hmm. Yes, and even now, it's like I said, it's a lot of education because, you know, we're reintroducing the curriculum where we're talking about, you know, for example, why do certain groups are hesitant to answer surveys, right? So introducing staff to Tuskegee case, for example, these are not things that people are naturally exposed to unless you're intentional about the type of curriculum you also want. And so even then, it's an understanding, you know, learning that, okay, even within our education sector, there are reasons why we're not really talking about slavery and we're not talking about the Holocaust as much. It's intentional. And so it's hard, it's emotionally hard, but once you start implementing it in practice, you also see the relationships that start to change even with the community members, right? One of the things that I've loved to see is our environmental health. You know, we have an environmental health program manager who is taking on some different strategies in terms of how to address some of the notion that environmental health is the enforcement, right? So that building that relationship, equity work is about building that relationship with the community members and ensuring that they know our goal isn't to be punitive, but to also work with them and empower them and to get them to where they want to be.
Absolutely. And you've touched on this a little bit already, but how is this equity work and the systems thinking approach kind of driving all of the decision making that your organization's doing?
So once we realized that what we wanted to do in terms of equity work is have that systems thinking approach, we reached out to Engaging Inquiry, which is a phenomenal consulting firm that is purpose-driven. And really their approach is community-based participatory research. So we convene a group of stakeholders from different sectors, and Dr. Haymaker being part of one, where we started having discussions about what accounts for the level of equity in our community, because we also want to capture what's working well. Sometimes when people discuss equity, it seems to be always negative, but there are things that are working well within our system. And so we wanted to capture that. And so based on some of that data and feedback, what the consulting group did was create a systems map of different loops, you know, virtuous loops, those are that are working, vicious cycles, those that are not working and continue to perpetuate a cycle where people are stuck, and stagnant also. Like there's systems set in place where people can't get out of the system. They're stuck where they're at. And so through that, we were able to merge it to look at our system. And what we plan to do is now socialize the map. And so through socialization, what you actually do, you have to test out the map with different community groups and ask them, like, does this map resonate with them? Do they feel that we've captured what is actually going on in our system or not? And also create an environment in which one can empower them to share their narratives, because this is an opportunity for both us as leaders in the community and community members to come together in terms of understanding data, but also ensuring that we collectively implementing solutions that are conducive. So we no longer want to take this approach that we know what's best for our community members. We think we have intelligent community members that truly know what they need, and we want to create that space for them to be able to share that with us.
Yeah. Can you give us some examples of some of the feedback loops you guys are kind of looking at or dealing with or working through?
Yeah, so there's one, and Chris, that's the question you should also ask Chris, because he is great at this. But there's one that we worked on, which was, it's called the Obama perception, right? So, and it basically talks about, here is, we have the first African-American president. And so there's an assumption that we don't need to work anymore on equity because here we have an African-American president. So, so that really reduced equity initiatives, because there was a sense that we have arrived, we have made it, and that wasn't the case, because now we see more equity initiatives and discussions and issues of racism and violence, gun violence occurring. And so for us, there was that it's called the Obama perception, basically the idea that here, because we have a Black president, we have moved the needle forward, when in reality, what it did was that it just silenced the voice and the need to do more equity work. Interesting.
Chris, do you have anything you want to add to that? And then we can kind of ask you a couple different questions as well.
Yeah, maybe just briefly. I mean, I think one of the things that I learned in this process, particularly in the systems mapping piece, is just how adversely segregation is interfering with relationships. We wind up with this segregated community where there are few opportunities to interact with people who look different from you and who have different cultures than you and solve problems differently than you. And so as a result of that, you have this fear that develops in between groups. And this is one of those vicious cycles that is really maintained by a number of different subsystems, right? But it winds up, this segregation builds fear and avoidant behavior, and that avoidant behavior then winds up continuing to sustain that segregation to all of our detriment. I think one of the big things about this is that one thing that I admire about the health department's willingness to sponsor this conversation is that it puts relationships and relationship building at the center of this ongoing conversation. And in spite of my own impatience to leap ahead and to try to solve some of these injustices, because I'm very passionate about it, I think that Dr. Egbuonye is right that we really need to have a full community-centered conversation about it that builds up these relationships and really boosts everyone's perceptions that diversity is a source of creativity and problem solving.
Yeah, and what has it been like to be a stakeholder in this kind of project and work?
Humbling, and just it's very emotionally challenging, these conversations that we have, and I've really been grateful that all of our facilitators have been willing to attend to those emotional components, because it's made it feel safer, I think, for everyone to talk about where they're coming from and what they have to contribute. Boy, they've normalized the wide range of emotional reactions that we can all have in conversations about race in this country. And so I think it's just been really emotionally difficult and profoundly rewarding to be around this group of people. And I say humbled because I have learned so much through my participation, and I hope that I have been able to contribute a little bit. But I think it is such a worthy long-term task that I am just determined and committed. So it's been good. It's been good.
Good. So how have you taken some of these things that you've learned and kind of implemented them into like your everyday work and your work with adolescents?
Well, so maybe I could tell just a few stories. I mean, I think in my work in this residency program, right? So this is a primary care facility, and so I'm teaching family doctors to interact with people of all ages, and I'm still having my my direct psychology therapy appointments, right? And so I have a different population of patients now than I did when I was in private practice. Sometimes I'm able to see people the same day that they see a doctor, and that reduces the barriers to people seeing a therapist, which I think is wonderful. And so as a result of that work, I have now in my therapy practice more folks from underrepresented minorities and African Americans in particular in this community. And one of the things that I guess I've seen that is a profound struggle for me is that I run into these teenagers particularly who in other ways are absolutely resilient, wonderful human beings, and run into a buzzsaw of discrimination and bullying and marginalization. And I've noticed that I feel helpless because I am a relationship with them where they see me once a week or once every few weeks. And gosh, I'm filled with empathy and I have lots of ideas about strategies, but I often feel inadequate. So I find myself in these situations where I'm wanting to help these folks out with things that are not the normal purview of a psychotherapist, right? So you run into an African-American teenager and you just want them to have mentors in the community. So I will tell you a little bit about two programs that I have found that I think are wonderful because they emphasize relationships in the context of a distressed system, right? So one of them is called the Hip Hop Literacy Program, and I'm going to talk about it. My son has been a participant in it, and it's just fantastic. And I feel a little bit badly that my colleague, Shoaib Meacham, he's an educator from the University of Northern Iowa, is not able to describe the program a little bit for himself. But I'm going to talk a little bit about what he shared with me. What they did this summer was they had 8 weeks of programming for 4th grade through 8th grade students who are interested in hip hop. And they will take as many as 50, and what you've got here are sessions from 8 until noon with small groups of 5 or 6 teenagers and preteens that are talking about what they are interested in, which is hip hop. Hip hop, for a variety of reasons, is really culturally significant. It's so powerful. And if you're interested in hip hop and you can create bars, then you are facilitating literacy in the context of a relationship. And my son was around this group. He's an African-American child, and he was around this group of other African-American kids and felt like he was a part of things. And it was just, I often cry when I talk about it because it's so moving. And I know that Dr. Meacham talked a little bit about the success of the program in other areas. 100% of the kids that participate in that, in other areas where they've been able to study it long term, have gone on to college. And that's a wonderful success, because I think what segregation does is it interferes with the relationships that people are able to build across socioeconomic groups, and it interferes with the resiliency that we can make in the context of a warm relationship. So that's one example. That's a sort of a personal example. The other example that I would have in downtown Waterloo is Try Pie. And this organization sells pie, traditional pie, cherry pie, raspberry pie. They have fine coffee, and they have a little store where they mentor early teenage girls. And these girls get a job there, and they learn how to make pie, and they have mentors in the form of volunteers that create these relationships with these girls. Sometimes they're just making pie side by side, but they're also hanging out, and they're talking about schoolwork, and they're learning how to engage other people in a professional manner, and they're just learning how to build these relationships, sometimes across cultural boundaries. And I said to them when I was able to meet with them that one of the things that I feel like is just so profoundly useful is that it doesn't really matter if it's pie or hip hop or knitting. It's the relationships that we're able to cultivate that are one of the things that are going to build resiliencies in our community. And so that's really what we need to make possible. And that's what I feel most passionate about. Everybody still there?
We can't hear you, Chelsea.
Not anymore? When did
I
it stop? Have I just been talking for like 5 minutes?
can hear you.
Oh, you can? Okay.
Yeah, it's Chelsea. I can't hear Chelsea.
Oh, I see.
Chelsea.
Can you guys hear me?
Yeah.
Yeah,
There we
now
go.
we can hear you.
There we go.
Sorry, I
No
muted
problem.
myself. I muted myself to take a sip of water, and then I got stuck on mute because everyone's supposed to be on mute. So I apologize. That was me.
It's okay.
Yeah. So I still heard everything you said, and it was great,
Okay.
Chris.
Yeah.
You weren't just talking into a void. So yeah, those two examples are really interesting, and like really I feel like do a great job of kind of like showing the different kind of work you guys are doing all over the community. Can you guys talk a little bit about how these kind of like smaller changes are helping to drive health equity across the community?
For the health department, yes. So I'll give you an example. We have one that's just, it's the community health needs assessment. You know, Chris really touched base on that inherent human connection. Like we have to have that. Like that's what's really going to need to move the needle forward. So when we started the community health survey, it was predominantly middle-class white respondents that we were receiving. And there's, you know, I think people naturally did not know how to engage the other, not the diverse populations that we have. And so it took building those relationships. And so I put it on myself. I said, you know, we're going to do this. And so we are working with Hakuno Tura, who's from Embark. And what he did was so we targeted the immigrant populations. So instead of just translating the survey into their particular language, we we were testing the surveys to see actually with their language, with the native speakers. So we used interpreters and said, you know, if we ask you this question, do you understand it? What does it mean for you, in your language and your culture? And so there was a little bit of tweaks that were happening, but we were able to get the Congolese, the Liberians, the Burmese, the Hispanic community to answer the surveys. And then going beyond just the quantitative piece, we're going to have focus groups and talk to them and dig a little bit deeper on what's going on within their communities. Within the African American community, I found out that there's a Black pastors meetup, and so I went I attended those meetings and explained to them the importance of the survey and what the data will help us to achieve. But you know, you have to be humble. You have to go in with good intentions, in truly listening to what their needs are and being available to cultivate that relationship. And so I never walk in there like I'm the health director. I walk in there, I'm part of this community, and because of my position, I have the opportunity to do something, but we have to do it collaboratively. And so, and that's why for me, and I have shared this with a group of colleagues, I know with Public Health 3.0, we're asked to be the chief community health strategist, and I don't like the term chief because chief signifies as if we know we're the lead in a sense, and for me it's just community health strategist. That's what the role of the health department is, and we can only do that collectively with everybody being at the table.
Definitely. And then Chris, did you want to add anything about how kind of working on small changes in your practice or helping drive health equity?
Well, I mean, I again feel sort of humbled. I think I want to underscore this idea of really going out to the community and being community centered. In medical, in this medical facility, we really talk a lot about patient-centered care. And so part of what I do in the context of the education is I really try to make sure that our physicians who come here understand health systems and community systems and the sorts of discrimination that happen and how that affects health. And so I don't think I should probably talk about it extensively, but I would encourage people to look at any Kamara Jones videos you can look at. She is just a wonderful physician who is really focused on social medicine. And I feel like at least my physicians who graduate from this family medicine program will understand how to risk stratify based on some of the things that happen in our culture, that racism is real and it has real health consequences, and immigrants often suffer from a very predictable pattern of health vulnerabilities that we can attend to if we have the compassion and awareness to attend to them.
Great. So I've got one more question for our panelists, but if any of our viewers have anything they'd like to ask, this is another reminder to please use that chat function on Zoom, and you can send me any questions you may have, and I'm happy to ask them. So please use this time. If you had anything that kind of popped up and you're curious about, let us know. So my last question for the two of you would be, what would you like this work to look like in the future? Say like the next 5 years, 10 years, or maybe even 20 years down the road. Why don't you start off, Nafissa?
Oh, wow. I think for me, is that we have to have interventions at all levels. I do think that part of racism and the historical inequities have resulted in trauma, and trauma from all walks of life, right? So, and we see trauma in all demographics. And so I really like the trauma-informed care approaches that I've seen. But my hope is that as a community, we'll have measures that in place in which interventions can happen at all levels. And I'll just throw in an example out there. You know, let's say that we have live data that's demonstrating, and we're all interconnected. There's a child that has missed 3 days of school. And so as the different disciplines, we have to be able to zoom in and say, why has this child missed 3 days in school? So health department is tagging with Chris. We're all saying, okay, what's the intervention here? What do we need to do? And then perhaps mom is struggling with paying the rent, or there's no food, right? So then we have the different social services that are ready, you know, in place to be able to address some of these issues that the family is dealing with. I think that if we're going to have a systems thinking approach, and when you look at the social determinants of health, we have to all play a piece in how we intervene. And so that is my hope, that is my goal for Black Hawk County, and I just hope we'll get there. It'll be hard, but who knows?
Absolutely. Chris, do you have anything you want to add?
Oh gosh, well, in 20 years, I hope that people in Black Hawk County can talk about what they need and they can get it.
Yes.
And I think it's going to be, boy, there are going to be a lot of conversations along the way, and some of them are going to be difficult, and some of them are going to be rewarding. And my hope is that the things that we do together as a community become a lot more integrated and efficient and community centered, so that Nafissa and I can talk about that kiddo that missed 3 days of school, right? Or at least our agencies are having that conversation because of the relationships that we've built between the communities. And so that, I think, so that different communities in Waterloo can feel empowered to raise their needs, their concerns about healthcare and their concerns about financial discrimination, so that we can come together, right, across agencies, really. And that's just a lot to coordinate. That's a lot of relationships, and so I know that it will take more time than I want it to, but that's I guess what I hope will come out.
Yeah, absolutely. And one question we just got that popped in. So we know that a lot of urban communities have been kind of addressing issues of racism and health equity. What are maybe some more unique challenges and opportunities for this kind of work when it comes to rural communities?
So I think with rural, I just had this discussion with staff, is that the rural poor whites, the word privilege doesn't resonate, because it's been, my family's been poor. I've had to really work hard to get to where I am. What do you mean I'm privileged? I'm not privileged, right? So you have that, and you see that, especially when you're doing equity work. So you have to be able to demonstrate where the privilege or the advantage, I like to use the word advantage more often than privilege, so that they see how race can play an advantage within the system. And so And some of that is having scenarios. Some of that is introducing them to more of the historical literature and how even classism plays a role. Because part of the systems mapping is to really highlight who does this system really benefit. It's not benefiting poor white Americans either, right? And so it's to have people step back and see their similarities more often than their differences, because the system, as Chris stated, it creates a segregated group of people. So when you're segregated, you don't see the commonalities that you have. But it's such rewarding for me to hear some of my white staff that are like, hey, by the way, Nafissa, I'm the first person in my family to graduate from college. Really? How do we highlight that, right? So how do we demonstrate that there's more commonalities than differences? I think is the approach for rural America. And that's just what I think that we need to clarify also the word, what does privilege means, because it doesn't always resonate for those that have been in poverty for a quite number of years.
Yeah, I think that's a really great point. And an interesting way to kind of shift that phrasing to maybe make people kind of connect with it a little bit more. Well, if we don't have any more questions, I just want to thank everybody for their time today, and for both of you for sharing your thoughts. We really appreciate it. And thanks everybody for giving up your lunch hour to join us this afternoon. We really appreciate it. Next month, we hope everyone joins us again on November 21st. We're going to have Betsy Ritchie from the Iowa Department of Public Health here to talk about data use and confidentiality. So the Iowa Public Health Association Education Committee is still trying to plan these lunch and learns for the rest of the year. So if you have any suggestions or you have any stories that you'd like to share yourself, please let them know. And if anyone's interested in joining the committee, you're more than welcome to do that as well. All of the recordings for our Lunch and Learns are going to be archived on the Iowa Public Health Association's YouTube channel. You'll also be able to find other webinars there that you may have missed or want to revisit. So thank you again so much, you guys. We really appreciate it, and we'll see you all next month.
Thank you, Chelsea.
Thanks.
Thank you
Have a good
so
one.
much. Thank you.